Good afternoon, ladies and gentlemen. We might make a start. I think there are some people still outside enjoying lunch, and hopefully they'll join us soon. My name is Mai Krishnasamy. I'm the Chair in Cancer Nursing at the University of Melbourne and also the Research and Education Lead for Nursing for the Victorian Comprehensive Cancer Centre. Before anything further, I would like to acknowledge the traditional owners of the land on where we meet today, the Wurundjeri people of the Kulin Nation. I obviously need more coffee. And I would sincerely like to pay my respects to their elders, past, present and future. We have a really special sort of Monday Lunch Live for you today. But before I introduce our speaker for today, I would just like to draw your attention to some other events that are coming up in July through the Monday Lunch Live series here at the Victorian Comprehensive Cancer Centre, which for many of you, I'm sure you'll be aware, is an organisation of 10 Alliance partners that has been brought together and committed to really delivering the best outcomes and experience for people through research, education and the best clinical care possible. And over the rest of the month, we have, into August, we have a series of great speakers at this time on a Monday. The first one next week, following our speaker today, are the Peaky Awards, where we'll be celebrating our 3 award winners for this year, who are early career researchers, and they'll be receiving their awards and telling us a bit about their work. On the 16th of July, we'll have Declan Murphy, and Declan is a uro-oncology surgeon who's coming to talk about a surgeon, a scientist and a robot walking to the bar. And for those of you who may know Declan, you know you're in for a treat, so I would come in here just to see what the tail end of that line is. On the 23rd of July, Julian Savulescu is coming to talk about autonomy, futility and assisted dying. And then followed on the end of the month, we will have Chris Jolly coming to talk about antibody hypermutation, evolution on speed dial. And then into August, we'll have Julian Vivian coming to talk about KIR receptor cells and regulating NK cells, or natural killer cells in health and disease. So we've got a lot of great things coming ahead. But it is my real, genuine pleasure today to introduce Dr. Supriya Mohil to you. So Dr. Mohil is a board-certified geriatrician and oncologist. And forgive me for reading this, but there are, hi there. Can we, oh, I'll find out, is there a way of turning Erin? Oh, as we go into the talk, the slides will be darker and but if it's still a problem, please let us know. So I'm just going to read about Dr. Mohil because there's a lot of important stuff to say. So she completed internship, residency and fellowships in hematology, oncology and geriatrics at the University of Chicago Medical Center, where she also earned a master's degree in health outcomes research. Dr. Mohil's fellowship was funded by an American Society of Clinical Oncology, ASCO, and John Hartford Foundation initiative to train oncologists in the care of older adults. So Dr. Mohil's research interests include the evaluations of patterns of care, health outcomes and quality of life related to treatment for systemic cancer in older patients. She leads the cancer care delivery research efforts in the research base and sits on the Cancer Care Delivery Research Steering Committee at the National Cancer Institute and is an expert in geriatric oncology with over 130 publications in that area. She serves on the editorial board of the Journal of Clinical Oncology, is editor-in-chief of the Journal of Geriatric Oncology, and chair of the ASCO, the American Society of Clinical Oncology, Geriatric Oncology Task Force, and the ASCO Geriatric Oncology Clinical Guideline Panel. So we have a real expert here with us today, and today in her presentation, Dr. Mohil is going to talk about improving the care delivery of older patients with cancer, and we'll discuss results from 2 large studies that have been undertaken in the United States that examine models of care for older patients with cancer, and we'll talk about some of the positive results from those models of care studies that have shown improvement in communication between older adults, caregivers and medical professionals, and we'll discuss some of the ways in which these can be implemented into models of care. So Dr. Mohil, thank you very much. Welcome. Please join me in welcoming Dr. Mohil. Thank you.
So you'll have to put up with my American accent, not the beautiful Welsh accent that we were just listening to. So it's a pleasure for me to be here. As was mentioned, I'm from the United States, and I'm doing a research sabbatical and traveling through Australia. Part of my role now in my career is to really spread the world and spread knowledge about geriatric oncology. And so I invited myself to many Australian hospitals and institutions to be able to give lectures and talk about what we're learning from research in geriatric oncology. I'll talk today about the epidemiology of cancer and aging. Because I'm in the United States, a lot of the data that I have is from the United States, but it's very applicable to Australia, and that Australia is a Western country and follows along with some of the patterns of care and epidemiology that is the same in the United States. I'll talk about geriatric assessment, which is a way to evaluate an older patient with cancer, to guide assessment for treatment, and also to guide interventions. Geriatric assessment can help us predict outcomes. It has implications for decision making and implications for interventions that could improve outcomes of older adults with cancer. And I'll discuss, as was mentioned, clinical trials using geriatric assessment, both my own and others, that have shown geriatric assessment can really improve outcomes for older adults with cancer. So this is why geriatric oncology is important. Most people with cancer are older, and when I say older, I use the age 65. In the United States, that's because of our insurance, Medicare, and there is really no chronologic age for older. To me, older is really people who have other health status conditions outside of cancer. And geriatric oncology as a field is really interested in caring for those older adults for whom cancer may not be the only health concern, that those patients have other health concerns such as comorbidities, disabilities that might influence care outcomes. In terms of epidemiology, the fastest growing group of patients with cancer are those patients aged 75 and even 80 and over. There are days in my clinic where everybody I see are over the age of 75. I, by preference, take care of older patients in the clinic, but when I talk to my colleagues, it's common now to see very fit older adults presenting for evaluation and treatment. And our systems are such, in terms of our clinical trial structure, where we don't gather evidence of safety and efficacy of treatment for this population specifically. We have an age bias in our clinical trials, and the patients that are enrolled are not always the patients that we're seeing in clinic. Here, this is data from the United States. SEER is a national registry, a population-based registry that reflects people who have cancer across the United States. And the NCI does, as you know, National Cancer Institute does big clinical trials that establish our evidence for treatment. This shows the prevalence of people in the population in the United States with these diseases by age group, but also the prevalence of people who are enrolled onto clinical trials in these age groups. So I like to focus on colorectal cancer and lung cancer. As you can see, it's not about 37% of patients with lung cancer and colorectal cancer who are diagnosed are not just over the age of 65, but are over the age of 75. Yet only 9% of people with colorectal cancer enrolled onto clinical trials are over the age of 75, and only 15% of people enrolled onto clinical trials with lung cancer are over the age of 75. As you can see then, this creates a gap in when we're establishing evidence for treatment that does not reach our older adults and can really affect how we think about treatment for older adults. The gap leads to outcome disparities in outcomes. So this is a study from JAMA that looked at older adults and those from minority backgrounds in the United States and showed that the older population was not experiencing the benefits in cancer treatment at the same level as younger patients. And that was also the case of those who are from minority backgrounds. So we know that there's been significant advances in cancer treatment in terms of clinical trials, new treatments, immunotherapy, targeted agents. But because older adults are not enrolled, they're not experiencing the benefits of those treatments. And this is really due to two reasons, over-treatment and under-treatment. There are people who see an older adult, maybe someone who's 80 that comes into the clinic, And they say, well, the clinical trial compared 2 drugs versus 3 drugs. So I have to give my patient who's 80 the 3 drugs because that regimen was improved over the control arm, which was 2 drugs. And that patient who is 80 may have other problems like disability, comorbidities, that may put them at higher risk from that 3-drug regimen. And if one looks at the trial, people who are 80 may not have even been included. But because there's no data, the doctor feels inclined to treat with what they think is the evidence and what may be in the guidelines for that disease. On the other hand, there may be someone who looks at the patient and says, well, that patient looks a little bit more frail. I don't want to treat them at all because I don't know what to do. Not only does the 3-drug regimen I don't have data for, but the 2-drug regimen that was also studied in fit younger patients, which was thought to be the control arm, I don't have data for. So I'm not going to treat the patient with anything. We are all supportive of shared decision-making in terms of working with doctors, the patients, and the caregivers together to make a decision about treatment. But in reality, the physicians guide the process for treatment. And when there's a lack of data, it becomes very complicated in terms of how to make decisions because we don't have the information for what to do. So again, older patients are different than younger patients. They have a heterogeneous health status. When a younger patient is diagnosed with cancer, that cancer is usually the only significant health problem or the major health problem for that patient, which as a doctor, I'm going to treat that patient aggressively no matter what for their cancer because that makes sense in that specific context. Older patients have a higher prevalence of comorbidities, which are presence of 2 or more conditions outside of cancer. They also have a higher prevalence of disability, which are functional issues, cognitive disability, physical performance disability that can interfere with the ability to take care of oneself in the community or take care of oneself at home. And geriatric syndromes are more common. These are hallmarks of frailty. If an older patient has a geriatric syndrome such as dementia, significant depression, falls, they're at much higher risk of adverse outcomes from any aggressive intervention, whether it be surgery or chemotherapy. And so one should think closely about what to do with patients who have geriatric syndromes. These different issues or conditions are not the same. We know each are independently predictive of outcomes. We have often seen older patients come into the clinic and you open the chart up and they have 10 problems on their medical history, but they run into the clinic, they're working, they're taking care of their grandchildren, they're biking 4 miles a day. That patient has comorbidities, but not disabilities or geriatric syndromes. On the other hand, we have patients who come to the clinic who there is nothing listed on their medical chart or very little, not many medical problems, maybe mild diabetes or mild hypertension, but they're wheeled in by their daughter in a wheelchair. And when you talk to them, they have cognitive issues and they have trouble managing their finances, and the family's really stepped in to care for them. We do a really great job in our medical history taking of the comorbidities issues and not as well of a job in the disability issues. It's quite common that I'm not aware of disability when I look at a chart of a new patient I'm about to see, because it's not recorded. We don't record things like activities of daily living, which are the ability to take care of one's basic needs, or instrumental activities of daily living, which is the ability to take care of activities that allow someone to live independently at home. And we definitely don't do a poor job as a medical system of identifying cognitive impairment. We don't screen commonly for cognitive impairment, and cognitive impairment is quite common in people over the age of 70. When I was first in training now 15 years ago, the oncology colleagues that I had said, prove to me that cancer isn't the biggest problem for older adults. My patients with cancer don't have any other problems. I have to treat them aggressively. And so we undertook looking at a large population-based database of what the prevalence of some of these entities are, comorbidity, disabilities, geriatric syndromes, and patients with a history of cancer compared to those age-matched cohorts of people without cancer. And what we found was the prevalence was just a bit higher in the patients with a history of cancer, lending me to think that cancer and/or cancer treatment may actually increase these issues in this population. But these issues were certainly there when the patient was being treated or is being treated with cancer. So just because someone has cancer doesn't mean the other problems disappear. They're still present and need to be evaluated for. About 1/3 of patients are fit, meaning that they have few limitations in function or only mild comorbidities that don't significantly affect outcome. 50% are vulnerable, which means they have things like instrumental activities of daily living or physical performance problems, but that are not life-limiting concerns. And about a quarter of patients are frail, meaning they have an activity of daily living issue or dementia. And so that's how we think about the heterogeneity of older patients. So what is geriatric assessment? So geriatric assessment is an approach to the evaluation and of older patients that can lead to early identification and treatment of areas of vulnerability. Geriatric assessment uses validated tools such as function, objective physical performance, comorbidity, cognition, nutritional status, psychological status, and social support. And we know that each of these, what we call geriatric domains, independently predicts morbidity and mortality in community-dwelling older adults without cancer. And we're learning more that each of these domains independently predicts outcome in patients with cancer. And I'll show some data to that. But in the United States, as geriatricians, we use these tools very commonly to evaluate older adults, but it has not been adopted by oncologists because oncologists and the oncology community are not usually trained in taking care of older adults, even though the majority of their patients are older. So why geriatric assessment? So we recently published guidelines through the American Society of Clinical Oncology that stresses that every older adult, age 65 plus, should undergo some form of geriatric assessment if they're thinking about chemotherapy or receiving chemotherapy. And why is that? Well, geriatric assessment collects clinically important issues that otherwise go undetected. For example, in oncology, we use performance status, which is a very crude measure of fitness. It really measures the ability of how much a person is resting during the day. That performance status measure was evaluated and developed in younger patients about 40 years ago. It was never really validated in older patients to begin with, yet we use it for clinical trial enrollment. We use it in our clinics all the time to measure function. We know that patients with good performance status, so if you think about ECOG, which is Eastern Cooperative Oncology Group, or Karnofsky performance status, people who have a 0 or 1 ECOG or a 90 to 100% performance status by Karnofsky, many of them still are impaired on cognitive screening tests or are falling. And so those crude measures of fitness do not capture cognitive impairment well, significant comorbidities well, because they're just not good measures in older adults. We know that geriatric assessment is feasible to conduct in clinical practice and trials. There's quite a bit of data that shows this in the United States and all over the world, that it is feasible in oncology for geriatric assessment to be collected. We know the variables can identify older adults at high risk for adverse outcomes, and I'll show some data to this. And that we know that geriatric assessment can guide decision-making and interventions, and I'll also show some data for these. So here's an example of a study that shows geriatric assessment can identify patients at highest risk for adverse outcomes. This is a study from the Cancer and Aging Research Group in the United States, where they enrolled patients starting a new chemotherapy regimen. Everyone prior to that chemotherapy regimen received a geriatric assessment, and then they followed those patients and collected chemotherapy toxicity using NCI CTCAE toxicity, grade 3 to 5, where grade 3 toxicity is serious toxicity, grade 4 is usually requiring hospitalization, and grade 5 is death. For serious toxicity, for example, for grade 3 diarrhea is 6 bowel movements a day. Grade 4 is requiring usually intravenous fluids or hospitalization, and grade 5 is death. So you can imagine that grade 3 diarrhea for an older patient can be very significant to deal with 6 bowel movements a day. What we found in this study was that we could develop a tool that identified patients at higher risk for chemotherapy toxicity. And here are the variables that were predictive of outcome. So the top variables are variables that are routinely collected in clinical care. So age, type of cancer, dosing of chemotherapy, whether someone received one chemotherapy or multiple chemotherapy agents, anemia, creatinine clearance. These are things we routinely collect, oncologists routinely collect. What's not routinely collected is the bottom variable. So has someone had a recent fall, hearing impairment, limitations in walking a block, requiring assistance with medications, and decreased social activities. We get some of these questions in our history, but it's not standard that we ask all of these questions all the time to older adults. At least my colleagues, when I ask them, are you asking your patients about falls? They say no. It's not common for us to be thinking about that. But these variables identify patients at highest risk for chemotherapy toxicity. And they did that. This tool was better than Karnofsky performance status in identifying patients at highest risk for chemotherapy toxicity. In fact, physician-rated Karnofsky performance status was not able to identify patients. When I see an older patient who's 80, they commonly ask me, am I going to get sick from this treatment? That's what's important to me. Being independent is important. I will do the treatment if it doesn't make me sick. I want to be able to take care of myself. I don't want family to have to come into the home or take off work to come in. And if we're not using the correct tools to be able to accurately predict risk, then we're not able to talk about risk in a way that the patient can make an informed decision about treatment. And so if Karnofsky performance status or the eyeball test does not identify patients at risk, then a tool like this, which takes less than 2 minutes to do, could be used in the decision-making process for chemotherapy. Here's how I do it. So mycarg.org is a website that has cancer, it's in the Cancer and Aging Research Group. There's a ton of resources on that. In fact, almost all of our lectures are published on there. And I see patients in the clinic with colon cancer, and I often see patients with stage 3 colon cancer, and I have to make a decision about adjuvant chemotherapy. So these are two examples of patients with stage 3 colon cancer, 172 and 185. So 13-year chronologic difference in age. One might look at that age and say, well, the 72-year-old's not that old. Maybe I would treat that patient. The 85-year-old, that might seem old. And so maybe I won't treat that patient. And that's just making an assumption based on chronologic age. However, in this situation, the 72-year-old was frail, had a lot of health conditions and disability and cognitive issues that if they weren't overall assessed would have impacted decision making. The toxicity score was 15, which equated to a 92% risk of toxicity within 3 months, serious toxicity. The 85-year-old only had a score of 6. Very fit 85-year-old had only a 44% risk, which is more comparable to a younger population. And in fact, in my clinic, I treated the 85-year-old, but did not treat the 72-year-old. And I discussed why using the printout from the mycarg.org. And I said, you are high risk for toxicity, you have cognitive impairment, and it's unlikely that you're going to be able to complete chemotherapy in an effective dose that you would be able to establish the benefits for treatment. And that is the way I use it. So chronologic age is not appropriate in and of itself to help guide decision making, to help guide decision making for treatment for older adults. So we know that geriatric assessment can capture clinical issues that go undetected as feasible and can help identify patients at highest risk for toxicity. There's other data that shows that it also can help predict who's at highest risk for early mortality, which is a reasonable information for patients with advanced cancer. All of that literature is published in the ASCO guidelines, and that can be easily pulled up from the Journal of Clinical Oncology website. But how do we improve outcomes using geriatric assessment? We need to incorporate geriatric assessment into clinical trials and also see how geriatric assessment can help inform decision-making and outcomes. Here's a study in France where at the tumor boards, oncologists would make decisions in collaboration with their colleagues. In France, they were able to have geriatricians also see these patients. So they asked the oncologists in the multidisciplinary tumor board what decisions would they make about a particular patient. And then the geriatrician would give the results, and then they saw how many treatment decisions changed as a result of the geriatric assessment results. And in this study, 40% of recommendations changed, which means that that information that was captured in the geriatric assessment by the geriatrician was valuable to the oncologist in the treatment decision process. What influenced decision-making was activity of daily living dependence, so somebody who had really significant issues with their own care needs, and frailty based on a standardized tool called the Fried's frailty criteria. There's been one study that's used geriatric assessment to guide decision-making for treatment or to allocate treatment. This is a study in patients with advanced lung cancer, and this was before all our newer treatments came that are more marker-based. This was started maybe 5 or 6 years ago, and the study ended maybe 2 years ago. It was published in JCO last year. And what they did is they randomized patients to geriatric assessment or to allocation of treatment based on performance status and age. So in the control arm, which is performance status and age, patients who were less than 75 with good performance status got doublet chemotherapy depending on histology. And those patients who were over 75 with more poor performance status got single agent. And in the geriatric assessment, they were able to allocate risk stratify patients to fit. Those patients got doublet. Vulnerable, those patients got single agent. And frail, those patients got palliation, vet supportive care. In this study, the frail patients guided by geriatric assessment had a very short life expectancy, on average between 3 and 4 months. Those are patients more appropriate for hospice. And the other results show that toxicity was reduced in the geriatric assessment arm, and also treatment failures as a result of toxicity. What the geriatric assessment allowed for was more appropriate treatment of the older adult. So the fit patients actually got doublet chemotherapy, where in reality, someone who's 75 plus, one might just give them single agent because they think that chronologic age signifies that the patient is too high risk. Whereas the vulnerable patients got single agent, and the frail patients were spared chemotherapy that would not be beneficial from them. So although this geriatric assessment did not improve survival, it did improve toxicity and lowered treatment failures, which in the geriatric oncology community is very valuable for older adults. So I just showed how geriatric assessment can inform decision-making through the French study and through a clinical trial. How about geriatric interventions? So these are interventions we routinely do in the geriatrics and supportive care world, guided by assessments, geriatric assessments. So we take one domain, physical performance. We can use standardized tools to assess physical performance, such as falls, or an objective measure, such as the short physical performance battery that measures balance, gait speed, and leg strength. If someone has impairments on those tests, we can employ interventions such as physical therapy for lower extremity strength training. We can evaluate for assistive device. We can do home safety evaluations. For patients who are falling, who are going to get chemotherapy and don't have a caregiver at home, I always make sure they have a button to call someone if there's an emergency, if I'm planning chemotherapy with them. So there are some simple things we can do in conjunction with cancer treatment to help improve outcomes and prevent harm. From observational cohort studies, Hammaker published a systematic review that show that usually geriatric assessment guided interventions are recommended, and they're usually based on domain, nutrition, psychological status, cognition, for example, but it's highly variable. So in these studies, any intervention recommendation was on the order of 26% to 100%. So there is no standardized way to employ these interventions, and it's often based on resources. So in my clinic, I have a dietitian that sees the patient with me. I have an occupational therapist with a cognitive background. I have a pharmacist. Those are the people I pull in when there's a problem. But I might not have a social worker or someone else, and it might be harder for that patient to get those kinds of, counselor, and it might be harder for my patient to get those kinds of interventions when they're not there in the clinic. So a lot of this is resource driven. When we're designing clinical trials, though, thinking about developing an intervention based on geriatric assessment requires thought. And there's multiple ways to design a clinical trial. One could just look at one intervention for one problem, for example, counseling for depression. One could look at multiple interventions for one domain, such as dietitian, supplements, nutrition for nutritional problems. One could use a geriatrician like they do in France, where almost every older patient with cancer sees a geriatrician to assess and deliver the interventions. In those studies, one can imagine that the adherence is high to the geriatric assessment interventions because they're the ones that are assessing the patient, and they have the clinical judgment for the interventions and the interest in making sure those interventions are followed through. However, in many areas, and what I'm hearing about Australia, is that there aren't enough geriatricians to see all of the older adults with cancer as it is in the United States. And so thinking about that, oncologists who are seeing and oncology teams who are seeing their patients frequently should really be aware of what components are involved in geriatric assessment and what the interventions are, and can they be trained to do this. So in the United States, we took on the bottom, the last row, where we actually trained oncologists to do geriatric assessment and deliver care processes based on algorithms, which I'll show. There is the issue with adherence in this, that maybe the oncology teams won't follow through with some of these interventions, but this is a better way to disseminate in an area that doesn't have resources for geriatrics. So we have 3 grants in the United States, one to establish the algorithms, which I'll show. Then we have 2 clinical trials. One clinical trial is ongoing, and I'll show just some very brief results on that one. But the PCORI study, which is a study about patient-centered, that was funded by the Patient-Centered Outcomes Research, was completed and presented at ASCO in June. And I can present the results here today too. So here's the algorithms. This was published in JNCCN, and there was recently an article, sorry, it wasn't this study, I'll show you. There's recently an article in the Washington Post that highlighted a study about community oncologists, which I'll present the data on. But in this study, they're both published in JNCCN. In this study, we did the algorithms. And how we did that is we took 30 people across the country in the United States who are experts in geriatric oncology and ran clinical programs. And we asked them, when you do a geriatric assessment, what interventions are important? What do you do to take care of those patients when there's impairments? Because there wasn't really a standard process based on the observational studies. We wanted to create one from expert opinion. And we used a established Delphi consensus methodology to establish consensus on what people thought were the highest priority interventions. Here's an example, again, using the physical performance domain. So someone who is falling, has balance issues, or has a problem on the short physical performance battery that makes me think they're going to have a high risk of nursing home placement. These, for those patients, the interventions that were recommended by the experts were physical therapy, exercise, occupational therapy, and home safety evaluation. And they also, in their discussion about treatment, would assess safety, think about adjusting treatment. If someone had advanced cancer, for example, we use the geriatrics mantra, start low and go slow, rather than the oncology mantra, start high, and when they have a problem, go low. So we kind of do it the opposite way, dose escalate after the first cycle, which if someone is having problems with a lower dose in the first cycle, you know that higher dose is probably not appropriate anyway, and think about modifying dosage. So we were able to do this for each of the domains. I mentioned all the domains from geriatric assessment at the beginning of the lecture. The domains being function, physical performance, cognition, psychological status, nutrition. We have a sort of a battery of tools that are options, and there is no right one answer for which tool to use. We have in the ASCO guidelines practical considerations of what is the easiest to do. But if you're doing a research study, you could choose as long as it makes sense and is validated for older adults. So there's options. And then also process options. What kinds of interventions would be recommended if someone were to have an impairment on the assessment tool? And so that guided our intervention. And as I said, we had 2 large grants to look at the intervention. So the intervention is really doing an assessment for each of the geriatric domains and then implementing the recommendations for that through the algorithms for each domain. And so the first study got funded through the National Cancer Institute to see if a geriatric assessment and evaluation model of care could improve clinical outcomes. The clinical outcomes being chemotherapy toxicity. As mentioned, I showed geriatric assessment can help identify patients at highest risk of chemotherapy toxicity, survival, and functional decline in quality of life. And here's our model. So I talked earlier about treatment decisions and interventions. So we hypothesized that geriatric assessment model of care can improve outcomes, clinical outcomes, through more appropriate treatment decisions, like I showed from the French study in the clinical trial with patients with lung cancer, and through interventions like we developed in our algorithms. And so that was our conceptual model for this study. The design is a cluster randomized design. So we've randomized oncology practices across the United States. I think over 50 practices are participating in this study. The reason we did that is it's a model of care study. And so we can't do patient randomization. If we do that, a doctor who's taking care of one patient may really like the geriatric assessment and use it for the next patient, which could be a control patient. So we really randomized whole sites. And patients are 70 and over. They have incurable advanced cancer to participate, and they're scheduled to receive a new chemotherapy regimen, very similar to our chemotherapy prediction study where we saw a geriatric assessment predicted outcome. We're collecting all drugs the patient receives, all toxicities the patient gets, and the intervention is the assessment and recommendation. So in the usual care arm, the patients complete an assessment, but only clinically significant dementia and depression information is given to the doctor, no summary of recommendations. In the intervention arm, they get a web-generated summary. So the research assistants plug in the scores for the assessments, and it creates a tailored summary for each patient that also has a list of recommendations that the doctor can do. The doctor completely controls what they want to do with the patient. That patient is that doctor's. We just provided the information. In addition, the doctor does not have to do the geriatric assessment, which is a common misconception about geriatric assessment. We train the staff in the sites to do it. And in my clinic, I do not physically do the geriatric assessment. I am seeing the patients and making decisions with the patients. What happens is the patient does the assessment in the waiting room. The tech who puts the patient in a room and collects the blood pressure does the performance test and the cognition test. My nurse goes in and does the comorbidity assessment. I get it on a piece of paper in front of me. I open up the chart. I'm looking at the cancer stuff, and I have everything right in front of me. And I go inside into the clinic room with both pieces of information, the geriatrics information, the cancer information. And that's what we wanted to mimic in this study, and we did that. The doctor just got the summary and went into the room. We don't have results yet, so this study is scheduled to complete in early 2019. And I don't think we'll be ready for ASCO next year because it's a lot of cleaning of chemotherapy data. We do double reviews at our site. So the site staff assess toxicity prospectively, which you can imagine is a massive amount of work. And then we get all the clinic notes and we do a second assessment of toxicity. But we did look briefly at the first 60 patients for another grant, and I was surprised actually by how significant some of these adverse outcomes were. So 45% of patients at cycle 1 had grade 3 to 5 toxicity. 67% had grade 3 to 5 toxicity within 3 months. 25% were hospitalized. Half the patients required dose modification or discontinuation of treatment. 22% stopped treatment in 3 months. And then 8% entered into hospice and 8% died within 3 months. So very significant prevalence of adverse outcomes just in the first 60 patients makes me wonder about, again, treatment decision-making. How are people making decisions about treatment using data that they lack for a frail population? In the United States, we're inclined to treat. The patient comes to see an oncologist, we're inclined to treat that patient. But what we treat with is dose-reduced treatments that may not be safe in and of themselves. So the second study, this is a completed study. So unlike the first study, this study was focused on patient-centered outcomes, not clinical outcomes, because it's funded by PCORI. So we looked at communication about age-related concerns, and I'll talk a little bit more about that. Just like the other study, the intervention and the design were similar. The intervention was exactly the same. So the web-based tailored geriatric assessment and recommendations. And it was a cluster randomized study where oncology sites were randomized. The goals in this study were to improve communication about age-related concerns in patients with incurable advanced cancer and their caregivers. And we hypothesized that providing the assessment along with the recommendations would improve communication in the clinic setting. And we modeled that off of health-related quality of life and symptom management studies, where it's been shown that when you actually assess the patients and provide that information on paper to the doctor, that there's better communication about those issues in the clinical setting. And what are age-related concerns? So we did lots of focus groups with patients and caregivers, but we also used our clinical experience. Again, I take care of patients over the age of 70. I have 3 other geriatric oncologists at the University of Rochester who also take care of older patients. And we do geriatric assessment on all of our patients. And these are the questions we commonly hear. Because we have space and we're doing the assessment, people feel more comfortable bringing these issues up with us. Where in an oncology visit, when it's very focused on the cancer and the treatment, if nobody's asking about falls and cognition, it just doesn't come up. And the patients and caregivers don't know that it's important. And so they don't bring it up necessarily. But in our space, we have permission because we're doing these assessments. And what comes up all the time is, you know, my mom's memory is not so great. I've been doing her finances. Do you think the chemotherapy is going to make her memory worse? Or my mom has all these other medical problems. She's not taking her medicines the right way, I don't think. How can we get that together? I take care of a lot of older patients who are caregiving themselves for a loved one. And they'll tell me, if I go on cancer treatment, well, can I help my husband who has cognitive impairment? Am I going to still be able to caregive while I'm on chemotherapy? So these are very important questions that older adults and their caregivers have, but we don't talk about openly and can influence decision making sort of behind the scenes, where people may choose not to do the most appropriate treatment for them because of these concerns that are not being addressed. And so our study looked again at the intervention, looked at satisfaction with communication using a validated tool called the Healthcare Climate Questionnaire, looked at direct communication. We audio recorded the clinic visits in this study, both in the control arm and in the intervention arm after the geriatric assessment was done. We transcribed those and we qualitatively looked at all the data, looking at what was discussed in those clinical encounters. And we also are looking at health outcomes, health utilization, and decision-making for cancer treatment. And again, very similar design as the previous study. These are oncology sites that are cluster randomized, but our outcomes are different. The intervention is the same. Here's some of the methods. Again, we recruited in this study oncologists, caregivers, and patients. And so we enrolled the oncologists. Only patients from enrolled oncologists could participate. We consented the patients and the caregivers. All patients got geriatric assessment. At the intervention arm, the doctors got their web-based summary. After the intervention, actually after the geriatric assessment in both arms, we audio recorded. And about a week later, the patients got a telephone call from a separate team at the University of Chicago. I'm at the University of Rochester now, but a colleague, William Dale at the University of Chicago, his team called the patients up and asked about patient satisfaction. We're also looking at other outcomes like quality of life and function, but that data is still maturing. So we were able to enroll 541 patients, 413 caregivers, and over 300 doctors from across the United States. And I'll give briefly some results from each of these groups. These are pretty sick patients, incurable cancer, have a problem on the geriatric assessment. I'll show you some of this. These are patients that are not enrolled onto other clinical trials. They're excluded from almost every therapeutic clinical trial. And what we hear when people are doing research are these patients are too hard to recruit. We're not going to ever be able to recruit these older, more frail adults to clinical trials. But this study proves that you can do it as long as you are attentive to this issue and that the research question is important for the population. So for the oncologists, we did a baseline survey. And again, this is the study in JNCCN. In the baseline survey, every oncologist got a patient vignette, patient. where the vignette patient had advanced pancreatic cancer. And we varied 3 factors: age, 72 or 84, function, no functional problems or a lot of functional problems, falls, significant issues, and cognition, no cognitive issues or a lot of cognitive issues. So poor mini mental state examination score and needing help with finances. And then we asked them, would you give chemotherapy to this patient? And if so, what would you give? And it was 1 vignette and one or 2 questions about chemotherapy decision making. And what we found was it was highly variable if the physicians gave chemotherapy to these vignette patients. It was influenced by these variables: age, cognition, and function. So the patient that was younger, 72, and had no functional problems or cognitive issues, 97% of the oncologists that got that vignette patient would recommend chemotherapy, and most would recommend doublet chemotherapy. But only 14% would recommend chemotherapy to the 84-year-olds who had cognitive impairment and functional impairment. But look at the middle. It's so variable, all the way from 37% to 85%. And when we're talking about establishing standards and evidence so that every patient gets the same kind of treatment, this is not good when we see this highly variable number. It's sort of a coin toss with an oncologist who's give treatment. And that reflects the lack of data. The other thing that we can point out from this study was functional impairment, age, and cognitive impairment influenced the decision to treat, and also for those that were treated, influenced the decision to get doublet chemotherapy versus single agent. So when oncologists get the information about function and cognition, when it's given to them, similar to the Multidisciplinary Tumor Board study from France, they use it in their decision making. But yet in clinical practice, only 23% of oncologists say they're using standardized geriatric assessment tools in their practice. So when the information is collected and given to them, they think it's important enough to use in their decision-making process, but they're not doing it themselves. And some of this is training or recognizing how to do it in a way that's easy. The ASCO guidelines helps with that. Oncologists do care about older adults. They think there should be more clinical trials. They think the care should be improved. They want more training, but they're not using geriatric assessment. They also are not highly confident in a lot of geriatric-related issues, such as managing delirium, assessing nutrition, conducting functional assessments, dementia evaluation, fall assessment. I don't look at slight to confident, moderately confident, because most doctors think they can do at least a little bit of something, but I look at quite to very confident. So only 21% of oncologists are quite to very confident doing a fall assessment and intervention, when falls we know are predictive of chemotherapy toxicity, and there are standard community interventions that can be applied to improve outcomes for someone on chemotherapy who is falling. So these are gaps that we can improve. So in terms of the patients, again, the patients who were enrolled on the PCORI study were over the age of 70, had incurable stage 3 or 4 cancer. One of our eligibility criteria was that they had to have 1 domain impairment, again, screening in patients who are more vulnerable and frail rather than screening them out. So we didn't include polypharmacy because we knew that most older adults have polypharmacy, but we didn't know what the prevalence of the geriatric assessment problems in the community would be. What we wanted were the patients that had at least 1 issue on the geriatric assessment. And they had to not be on best supportive care on hospice. So most were receiving treatment. In terms of the arms, control arm versus geriatric assessment, the average age for both arms was 76. About half had GI or lung cancers. Most had stage 4 cancer, and most were receiving chemotherapy. About 70% of these patients were receiving chemotherapy. However, when we look at the geriatric assessment problems, this was actually quite astonishing to me. The number of problems was very high. So the median number of problems that patients had, so domain impairments, was 4. And almost everybody had, more than 12% and more of patients had more than 2 problems, so 3 or more domain impairments. So these are patients that we would call frail, 3 or more problems on a geriatric assessment, yet 70% were receiving chemotherapy in the clinics. And so there's sort of a gap here in terms of sort of how sick someone is and what they're getting in the clinic. Over 90% of patients had impairments in physical performance. As I as was expected, many had polypharmacy problems, comorbidity problems, basic functional issues, nutritional issues. Interestingly, over 30% of patients in both arms screened positive for cognitive impairment on a mini-cog. So these are patients, again, in the community who are not usually being screened, getting treatment for cancer, and when we screen them, they're screening positive for cognitive impairment. So highly prevalent, and yet not discussed in clinical encounters. And another thing that was interesting is we did ask about patient preferences at the study inception. So we asked patients, would they want a treatment if it could help them live longer, even if it would really impair their function, make them bedbound, make them require more assistance from family, cause their memory to be worse, cause them to be confused, or is maintaining quality of life more important than survival? And patients, for the majority, so I would say anywhere, depending on question, about 60 to 70% of patients, said that they would forego treatment even if it had a survival benefit, if it would cause these functional and cognitive impairments. So what we're seeing is patients on paper telling us one thing. They already have these problems on the geriatric assessment, and yet in the community, they're almost all of them are getting cancer treatment. So there's a gap in communication here about what's going on with underlying health status, what their preferences are for treatment, and what's actually happening. We looked at the audio recordings of the clinic visits, and we used a very rigorous methodology for the qualitative analysis. We had 4 coders, and they looked very carefully at all of these aging concerns. The way we captured aging concerns was based on the geriatric assessment, so we used the geriatric assessment to guide content analysis. So, for example, if there was a functional problem, then that was captured in the discussion. If there was a nutritional issue, that was captured. If there's a cognitive question that came up, that was captured. And this is one slide that shows the primary results of the trial. So we saw that in the direct communication, the geriatric assessment increased the number of discussions about age-related concerns. So in the geriatric assessment arm, on average, there was 8 discussions. In the control arm, there was 4.4 discussions. And of those discussions in the geriatric assessment arm, they were higher quality, meaning there was more back and forth with the doctor, just sort of talking about what was going on. So you fell, when did you fall? How did you fall? Tell me, did you get hurt? Did you go to the hospital? There was more conversation around the concerns. And there was more discussion about interventions. So you fell, what happened? And let's think about physical therapy. Let's think about how this will affect your treatment course. And so very significant improvement in each of these 3 things in the geriatric assessment arm based on a clinic encounter. And we also looked at satisfaction. And although the satisfaction scores were small, there was a significant improvement in the geriatric assessment arm, which was about 1.09 points higher. And thinking about satisfaction as a measure, there's usually ceiling effects. It's very hard to move satisfaction scores. And so the fact that we were able to move it a little bit was promising to us. So we thought that patients valued those discussions that occurred. And in fact, the value for both a general communication tool and for communication specifically about age-related concerns, that value lasted 3 months. So the difference in scores persisted for 3 months after the intervention. So satisfaction improved that improvement remained. When we look at what was discussed, and we're doing this more by domain, the quality of the discussions really did change. We looked at some of the early transcripts, so 20 in the control arm and 20 in the intervention arm. And what was talked about in the control arm about medicines was really what to do for supportive care. So if you have nausea, take this medicine. If you have diarrhea, take this medicine. It's sort of what we do in oncology clinics, right? Do this, do that, how's your pain? But when we looked at the geriatric assessment arm, they also talked about medication management. So how are you taking your medicines? When are you taking them? Are you taking all of them? Are you skipping them? And they also talked about number of medications. Well, maybe you're on too many medications. Can we take you off some of these high-risk medications? So just in the first few transcripts, there was more aging-sensitive discussions that were guided by the geriatric assessment. We also learned about the caregivers. I think there's very little information about caregivers of older, more frail adults who have advanced cancer. But, you know, I think we know this, but to see that 75% of caregivers are spouses who are also older and have their own comorbidities and healthcare needs, I think is impressive. 40% reported high levels of distress and depression, and the number of problems on the geriatric assessment increased caregiver distress or was associated with an increased caregiver distress. So thinking about now dyadic interventions where we do geriatric assessment not just for the patient, but if we know that the caregiver is older also, think about geriatric assessment of the caregiver and do interventions for both so that both are safe, I think is the next step in the research. I'll skip that. There are lots of other studies going on. So the minor that I talked about, COACH and GAP, are on the bottom, but there are 3 other large randomized studies going on across the world that are looking at geriatric assessment and improvement of outcomes. So Arti Huria is doing one at City of Hope. She's a leader in geriatric oncology at the United States. There's a French study of almost all of the regional centers, geriatric oncology centers in France, and then one in Canada. But if we look at the interventions, they're very geared towards healthcare system. So at the single institution study done by Arti Huria, they're using a study nurse practitioner to deliver the geriatric assessment. In France, they're using the geriatrician because they have access to geriatricians for all of their patients. In Canada, they have enough geriatric oncology programs to do it, so they're doing it with geriatric oncologists. And as I said, in the United States, I don't think we'll ever have enough geriatricians or geriatric oncologists, so we train oncologists. So that's more to come. I think in the next couple years, we'll get lots more information. So I hope I was able to show that older adults require special consideration for decision-making for treatment. And this is really due to a lack of evidence of risks and benefits. And because of the lack of evidence, we're inclined to either over or under treat. And that's informed by bias, really. And due to underlying health status conditions that can be heterogeneous, with older patients, we need to do proper objective assessments, just like we're sort of gearing towards personalizing medicine and cancer treatment using genetic markers. Geriatric assessment is a way to personalize assessment and treatment for an older adult. I've shown that geriatric assessment can help predict outcomes, and it can help improve the communication about age-related concerns. But we still need more data on how to get most oncology teams to implement geriatric assessment. The ASCO guidelines that are published have very practical guidelines of the highest priority assessment tools. That geriatric assessment is not like the one I did, which is super long. It's a research one, yet we were still able to get sites to do it. But the one in the guidelines takes, I would think, 6 to 8 minutes max, and most can be done by a non-physician, so somebody outside of part of the team, and it can be done in an organized way that will provide a lot of valuable information. So I hope I've convinced you that geriatric assessment is important for older adults with cancer. Thank you.
Thank you so much for an incredibly comprehensive overview, and I think presented some very, very powerful data. If we needed any convincing, I think we're all sold. But we have a few minutes for questions if anybody has a question from the floor. Yes, thank you.
Thanks. Sorry. I'm just wondering in terms of the interest of oncologists in actually or the comfort of oncologists in using a geriatric assessment tool. Do you think part of it might hinge on the fact that they may feel uncomfortable or that they may not have the resources or the time to address the broader issues that a geriatric assessment tool might raise? And then as a result, they may feel it's a bit open-ended as to where it goes.
Well, I think, so if you use the framework that I presented about decision-making and then use the algorithms, which are also in the ASCO guidelines, I think that second piece is, okay, you do it, then what? It's explained. So there's a box at the end of the guidelines about what to do for each impairment. So very simple kinds of things that we know in the geriatrics literature improves outcomes for older adults that can be used. I will say, having worked with many oncologists who feel this way, as soon as they do it a few times, they feel like that information is valuable. And our clinic in the University of Rochester, I started in 2010. I would have 3 referrals a week. Now I have had to hire 3 other people to manage the volume, and I'm in a small center in the United States. It's because it's part of our culture to do this, and because oncologists and even surgeons are familiar with the terminology and feel comfortable with it. So just like any new treatment and any new therapy or test, we have to get comfortable with it. And that's the same for this. There is an editorial in the Journal of Clinical Oncology that's called Stop Saying Geriatric Assessment is Too Time Consuming. When we think about all of the other things we do for older patients or patients in general, CAT scans, bone marrow biopsies, setting off genetic markers, doing bone marrow transplants, those things are so costly and so require so many resources. To ask a 5-minute assessment, which we know can identify patients at high risk and can improve communication about treatment, I think is low order. And so it's just really changing culture. There needs to be an advocate, I think. When we see in our clinics there's somebody who really cares, and that advocate does not need to be a physician. There's a nurse practitioner, what we call advanced care practice provider, social worker. It just needs to have someone to set it up. And once it's set up and it's routine, it becomes part of culture.
Hi, thank you so much for your talk. Can I just ask, in the first study that you mentioned, the randomized study looking at CGA and providing the oncologists with a list of vulnerabilities and impairments, did you collect data on how frequently the oncologist did then follow the what's next step and make a referral? Because in the orthogeriatrics literature, the studies were all negative until they took control of that step away from the other party and really needed the geriatricians to try.
Absolutely, and I'm part of the reason we made the PCORI patient-centered outcomes was I'm not sure about adherence. We collected lots of data on what the oncologist said they wanted to do, who did it. So was it them who made the, actually had to follow through with the logistics of getting a physical therapy referral or social work referral or home care, or was it someone in their team? And then 1 month later, we collected information back. We have not cleaned that data yet. This study just finished. And so we're going to look at that about what happened. And we're also looking at clinical outcomes. I'm not convinced that in the PCORI study, clinical outcomes will be improved because our study was very heterogeneous in the patients that were enrolled. They were enrolled at any part of their cancer treatment and with any kind of, so we had patients with breast cancer and hormonal treatment. But in the first study where we're still accruing, the hope is, we have patients who have frailty who are getting all chemotherapy or high risk medications. The hope is that we can see that if their interventions were employed, that will affect clinical outcomes. And we're also collecting adherence to the recommendations in that study also. But you're right, the geriatric studies do show that. And actually we had a pilot that showed that too.
Any other questions? Well, thank you so much.
Thank you.
I think it's been an incredible in-depth exploration for us, and I think has really set us a challenge as an Australian community, which we're always up for, I think, and hope that we are for this one. I think you've given us huge food for thought about what we can do and what we need to be doing to engage in this conversation. So please join me in thanking Dr.